Welcome friends, let us learn PhacoTrab, that is phacoemulsification with trabeculectomy. This patient has open angle glaucoma with cataract and we have decided to do combined surgery, that is trabeculectomy with phacoemulsification. Conjunctival peritomy is being done for about 2 clock hours from 11 o'clock to 1 o'clock. The sclera is nicely exposed. If the sclera is not nicely exposed, formation of bleb becomes difficult. So we must expose the sclera. Moreover, we should not apply cautery over Tenon's tissue. Now, a very mild wet field cautery is being done. This step may be avoided, but very mild cautery is good for beginners, because if it is bleeding, it becomes difficult to get a nice flap. And now this is 50 number Bird-Parker blade, and this is a triangular incision over the sclera. Good to get a triangular scleral flap. This is a crescent blade. I'm going to dissect by the crescent blade so that I get a smooth surface. I also use 50 number Bird-Parker blade for this dissection. With crescent blade, I tend to get a thicker flap. Anterior flap becomes thicker. So there is a chance of premature entry. I have kept the 50 number Bird-Parker blade ready so that I can safely make the flap at the limbus. This is 15 number BP blade. We have to be very careful. There should not be any buttonhole in the anterior scleral flap. And now at this stage I'm going to apply mitomycin C. This is a small cotton ball which has been soaked in mitomycin C solution. This step should be done with cellulose sponges, but we don't have that. But with cotton tipped Johnson Bart also I have got good results, and there is no complication till now. And now the phacoemulsification part. The main incision is at 9 o'clock and a side port is there at around 2 o'clock. Capsulorhexis is being done. Size of this rhexis is about 5.25 millimeter. Hydrodissection is done with BSS and 27 gauge cannula. The nucleus is rotated. And now I am going to use the pre-chopper to divide the nucleus into 3 pieces. So the nucleus has been divided into 3 pieces, and now emulsification of these pieces will be carried out. This is Oatley Caterex 3 phacomachine. Vacuum is 400 millimeter of mercury. Flow rate is 40 ml per minute. Ultrasonic energy in this case is about 70%. You can see that the cataract is not very soft. It is about grade 4 and definitely not grade 3 cataract. We had a good red glow, and a very good red glow is deceptive many times. It becomes difficult to judge the hardness of the nucleus. Many a time it gives a false notion that the nucleus is soft, but actually the nucleus may be quite hard, like in this case. And now the cortex is removed. This is a 23G Simcoe cannula. Yes, the cortex has been nicely removed. And now I'm going to enlarge the main wound a bit and then implant a monofocal single piece monofocal intraocular lens. This is a hydrophilic acrylic lens. The lens is nicely placed in the capsular bag. This is an air bubble, and now this is pilocarpine. I want to constrict the pupil because I want to do a peripheral iridectomy. After removing a piece of sclera containing trabecular meshwork, I will do a PI, that is peripheral iridectomy. I waited for some time and then I had an idea. I took the 23G Simcoe and I just hold the margin of the pupil by the aspirating port and pull it centrally. And this maneuvers caused constriction of the pupil. So the size of the pupil is about 4 millimeter at this time. And now I'm going to remove a piece of sclera containing trabecular meshwork at the limbus underneath this triangular scleral flap. I asked my assistant to clean this area, and now this is one horizontal incision and this another one almost parallel to the first incision. This is the piece of sclera and this contains trabecular meshwork. And now I'm going to do a peripheral iridectomy. In my left hand is the rhexis forceps to hold the iris, and right hand is a Vanna scissor, and I did a good peripheral iridectomy. You can see the red glow through that iridectomy. And now this is cleaning the area. There should not be any visco there, and I'm planning to put some sutures at the apex of the triangular flap. I put a suture, and this is going to be a permanent one. I'm not going to remove it. So this is not a releasable suture, this is a permanent suture. 2 throws, hold, pull, one more throw, and then one more throw. The threads are trimmed near the knot, and the knot has been buried. And now I am going to put a releasable suture on the left arm of the triangular scleral flap. Here I go from outside the conjunctiva to the inside, and then take bites anteriorly on the flap, posteriorly on the sclera. And now in this case, for this releasable suture, I have put 4 throws. Let us count. 1, 2, 3, 4. 4 throws, and now pull the threads. Four throws usually don't slip. 3 throws may slip. And now I cut the longer thread with the needle near the knot, near this releasable knot. And now on the right arm of this triangular scleral flap, near the limbus, this is a permanent suture. This is not a releasable one, and this is going to be a 2, 1, 1 knot. This is two throws, and then 1, and then this is the last one. The knot is buried in the tissue. And now near the apex on the right arm of the triangular skeletal flap, this is another releasable suture. And I'm going to remove this releasable suture first. And this one is going to be 3 1 1. No, this one is going to be 3 throws, 1 2 3, and then just pull and cut the thread with the needle. And before that, I'm going to remove the visco that is there in the anterior chamber. We can see the big PI This is another wash with bimanual irrigation aspiration to remove the visco nicely. This is air bubble, and this is oxy. This is moxifloxacin. Now I'm going to cut this thread. And now we are towards the end of this long surgery. Cut the superior rectus bridle suture. Reposit the conjunctiva. Near the limbus. And now I'm going to put some sutures so that this conjunctiva is nicely opposed to the limbus. This is moxifloxacin. This is one releasable suture. The bleeding started. 3 throws and just pull. Another releasable suture on the other side, on the left side of the peritomy, left corner. 3 throws, 1, 2, 3, and pull. Now the conjunctiva is nicely opposed to the limbus, but we should not leave this as such in traps. I'm going to put 2 matrix switches here, coming from the limbal side to the conjunctival side, and then going back. I'm using smooth switcher tank forceps, not tooth forceps, because if we use tooth forceps we can tear off the conjunctiva. This is on, not. The conjunctiva is just opposed, not a tight switcher, just opposed. And one more matrix switcher. Here. From limbal side to conjunctival side, and then going back from conjunctival side to the limbal side. Now watch the knot. This knot should be very thin, that's why it is on, knot. This is moxifloxacin. And now this is a bit of mitomycin. Thoroughly wash the conjunctiva. One, another one, and then another one. Cut the threads. These 2 knots are not buried. These 2 knots will be removed after about 1 week or so. This is the final lavage of the anterior chamber. I have some post-op pictures after 48 hours. Thank you very much for watching, but wait for the post-op pictures. See, after 48 hours the cornea is very clear, crystal clear cornea. Antechamber is quiet. Intraocular pressure is normal. It is 18 millimeter of mercury. I'm going to remove this releasable suture so that intraocular pressure becomes little less. I want the IOP about 12 millimeter mercury, 10 or 12 millimeter of mercury in this case. Thank you very much for your attention.